And let me do that now. Okay, check now. Can somebody check the YouTube? Is it the same YouTube this or?
It's not the same. No, sir.
Okay, that's fine.
This is not the same.
I've given another link now. Try that. Dheeraj,
Okay.
can you talk? Let's see if it works.
Yeah,
Okay,
so
sir.
I'm just trying to streaming.
Yeah.
Yes, now you can see it. What Guru? Yeah, I can see it.
Okay, you keep going.
Sir, this new one I will just share.
Yeah, do
Guru,
that now. Yeah,
okay,
yeah,
sir.
please do.
Yeah,
Please
yes,
do. Yeah, and go ahead, Dheeraj, or maybe wait for 1 or 2 minutes.
Yeah, I'll just.
Because I've gone live.
Yeah, only 3 people are watching it now as I'm.
Yeah, share that, share.
I shared the new link again, sir.
Okay, give 1
I
more
have
minute.
shared it in the group.
It will come up.
Okay, the viewers are slowly increasing. That's good.
It's good. Sorry, I'll get them a new link.
It's coming, sir. New link is coming.
Yeah, it's all coming. I'm just trying to see where I am.
Okay, sir.
What can you see on the new link?
Now it's only Dheeraj. He has stopped the screen sharing, I think.
Is the screen sharing working now?
For
Can you see?
Dheeraj,
I am sharing my screen. Can you see it?
Okay, wait.
Huh?
Yeah, there is a little bit of time lag. So give a little bit of time lag and then you will see. Now your screen is.
So can you guys can you guys see the screen in the Zoom meeting app?
No. Even in Zoom.
No, even in Zoom you can't see.
No.
No, but Guru.
Sir, yeah. Now we can see you, sir.
No, what I'm trying
Only
to say
sir
is
is seen, but the screen is not getting shared.
Okay.
Yes, your slides are not visible.
Give me 1 second. Dheeraj, can you make me the host for a second?
How do I do that?
At the bottom right.
Okay, guys, can I just tell you something?
Yeah.
Because you
on
should
Zoom?
be able. On Zoom, for some reason, your screen went blank.
So even in this thing also, in YouTube also it's blank.
Yeah. Can you reshare the screen? Because it is live, except that your screen is not coming up.
If you can start screen sharing again, Dheeraj. Because we are not out of this thing, na? Yes.
Now it's coming, sir.
Yes.
So now you can see?
Yes.
Yes, we can see now.
We can.
Actually, YouTube is a little bit like 5 seconds later than Zoom, so it will come after 5 seconds. I think.
Yes, it has come.
Yeah, I will do
It
that.
has come.
I can see in both Zoom and YouTube, both. But only 12 viewers so far. Yeah.
Yes.
They will eventually join.
People are joining in, I think.
So they can see. Yeah.
Yeah.
Again.
And they can watch it later also. No problem. Don't worry.
Yeah, true.
I think the thing is that can you all switch your phones off, yeah, on YouTube, so that because I'm getting the same messages twice, so it's confusing. So
yes, sir, it's coming both in YouTube and this thing.
okay, is it on now?
Yes, sir.
Okay. All right. Apologies for a slight delay in this last lecture, and I think this is the last lecture, and we're going to have a Q&A session after that. I'm sorry that we went offline for some time, but we are going to try and amalgamate this lecture with the other one so that you can have uninterrupted lectures when you actually watch the YouTube video. I'm sorry, someone's actually kept their YouTube going on.
It is recording. You can carry on.
Yeah, no, I think it just, I couldn't hear my voice again. That's why that was a problem. Okay, now it's sharing now, yeah? Guru, it's sharing, right?
Yeah, you carry on.
Okay. So I think it's very important to realize a thing that for some, death is a good outcome. And it is very important to make sure that just because sometimes we can do something does not mean that we should do something. In a proportion of people, a dignified death might actually be better than a prolongation of suffering. And I think these are the principles I use before I actually decide whether a patient is for CPR or not for CPR. There are multiple factors which contribute. It is like, what was a comorbidity, what kind of state I would get him to, what was the duration of CPR, what is the outcome the patient's ultimately going to have. And just because someone has ROSC with a couple of ampules of adrenaline doesn't mean that he has a sustained ROSC. For ROSC, you need to have a sustained ROSC and a decent blood pressure for everyone to actually be to have a good outcome. I'm sorry, can someone please mute your okay. So there was a survey which was done in the UK, and the results of the survey were as follows: that the majority of the people who were surveyed said that they would have actually preferred to die at home. A good death is as important as a good life. And if you actually look at the numbers, 60% of the deaths in the UK, that's around 300,000 people a year, die in a hospital. So they spend the last few years of their life or for last few days of their life in a hospital when they would rather be at home. And that's that's a lot of patients wish that would happen. And 22,000 patients out of these actually die in intensive care. Now, this might not be pertinent for our cardiopulmonary resuscitation talk, but the impact of ICU is actually very distressing for the patients. 75% of the patients have distressful symptoms after that. 57% of the patients develop PTSD, and 80% of the patients develop anxiety and depression. And for the relatives, it's almost 100% of the relatives find it distressing. It has got a physical, psychosocial, and spiritual effect on the relatives, and they actually require support for that. And not to mention, in a private healthcare system like in India, it can have a devastating financial impact because, when I talked about the story of Mr. Hatch, right from the beginning, we knew that the patient is not going to have a successful outcome, yet went into the hospital and got charged a humongous amount of money for the resuscitation. And hence, deciding whether a person will really benefit from resuscitation, actually, you have to take in account of all these factors. So the question remains is like, do we resuscitate or not resuscitate? And how do we answer that? The dilemma you usually have is like, if I try to resuscitate the patient, what is my probability of success versus benefit? All right. I might be successful, but is it going to be beneficial to the patient? Or I might not even be successful. And that's the reason you think about futility. Okay. If you have someone who's got a very severe aortic stenosis and you try to resuscitate, in all possibility, it might be futile. If you have someone with cardiomyopathy and who's got an ejection fraction of just 15%, normally, I mean, if you try to resuscitate, even with your best efforts, you might not be able to get the heart going. So always have to think about whether it's going to be futile, there's going to be benefit with what you're doing, and the probability of success versus benefit. And also another dilemma which normally people have is that who decides not to resuscitate and whom do you discuss this with? So in general, in the UK, most of the resuscitation decisions are taken by the consultant, or if a junior doctor takes this decision, he has to discuss with the consultant. The other person you discuss it with is if your patient has a significant chronic condition and is expected to die, you ask the patient himself at that time what are his wishes regarding resuscitation. And the patient might say, I might not want to be resuscitated. The discussions around this are very challenging. Most of the times when the patient comes into ICU or post-cardiac arrest, their relatives are the surrogate, and they are very honest with you. Sometimes if you talk to them and say, the amount of time it's taken to get the ROSC back, we expect that the patient is going to have an irreversible brain damage. The patient might be in a persistent vegetative state. Do you want us to continue the treatment? The relatives come back and say, my husband or my father or my wife always had a very different view of life. They have discussed with me and said that if they're ever in a condition where they were going to be bedbound and not knowing what to do, please don't go ahead with it. So these are the few dilemmas which we face. So you can actually have the ethical principles of beneficence, non-maleficence, respect for autonomy and justice applied when you're actually thinking about whether to resuscitate or palliate someone. We are primarily ruled by the rule of beneficence, right? So we always think that preservation of life for us as physician is the most important thing. Okay, but at the same time, we also have a responsibility of making sure that we can restore the health of the individual. We give relief from suffering, and we actually do not increase the person's suffering. And we have to make sure that this can actually be maintained and restored, or restored and maintained, right? So it's not just about, oh, you got the heart back now and everything's going to be hunky-dory. No, you just have to make sure that you can continue to maintain that. If it is just based on a couple of adrenaline boluses and you think that the patient's then going and having a cardiac arrest and then you actually have to give some adrenaline, it comes back. I mean, it's just the body deciding that the body is dying. Non-maleficence. I mean, one of the primary thing we practice as physicians is what we call as the primum non nocere, which is first, do no harm. Yeah. So anything which we do which causes harm, we have to be very careful about that. Resuscitative measures may be futile in patients where conditions where scientific investigation demonstrates ineffectiveness of resuscitative efforts, where you have conditions where people have got end stage, heart disease and is not on a list for transplant, and there's no way you're going to get an organ. There's no point, if you try resuscitating, you know that you're going to be futile, you're not going to get anywhere. Okay. Patients who suffer cardiac arrest despite optimal treatment to maintain vital function. There's a lot of patients who come into us with sepsis, with multi-organ failure. I've got 4 or 5 organ supports, 100% oxygen. The patient's actually on all kinds of inotropes, adrenaline going at a mic, NORAD going at a mic, vasopressin. And you know that you've actually done everything. And after that, if the person suffers a cardiac arrest, it's actually going to be futile. There's no way you're going to be able to get this patient back. And you have tried. So how long do you try? That's a question which was asked by someone. We'll discuss that later. But, if you have done appropriate resuscitative efforts and you've tried your best and still you're not getting ROSC, you should call it off. That's been a futile resuscitation attempt. Patient's autonomy has always to be respected. Yeah, that's the binding principle. The patient is ultimately responsible for his own health, and he has a right to accept or refuse treatment. Now, it's very important to understand that just because someone's making a bad decision doesn't mean he is competent. Okay, so you always have to establish a competence of a patient. So if you talk to a person, you find that the person is absolutely competent, and the person then tells you, I don't want to be resuscitated because I don't want to live like that. Just because you think it's a bad decision, that doesn't mean that the patient is taking a wrong decision. And his competence, if his competence is established, his decisions have to be respected. Yeah, the main thing which we could do is, one, how we give the information to the patient, how much the person has understood the information which you have given. Is the patient making that decision voluntarily? Sometimes, you have patients who have got their relatives on their side who are forced into making a decision on one side or the other. So usually in my practice, I talk to the patient alone, and then I talk to the relatives along with the patient and tell them the discussion which we have. Not everyone's happy with that, but it does something because it is the patient's own decision. It cannot be guided by his relatives or anything of that sort. Of course, after he talks to relatives and he changes his mind, which he has, you can. And authorization, either if the patient has not had capacity for some time, if the patient has given a power of attorney to anyone, then that authorization is binding and legal, provided it's on a legal document, and you have to respect it. Nowadays, we have advanced directives where patient can actually say that I would want to have this treatment, I would not want to have this treatment. I might be okay for hemofiltration, but you should not be putting me on a ventilator. They can do all that. But provided it's done in a legal way, we have a responsibility to accept that. So normally, consent to administer CPR in a resuscitation is presumed. That means for any patient who's had a cardiac arrest, you can start CPR. The only thing is that if a patient has an advance directive or there is any contrary evidence that the patient does not want to be resuscitated, or if the patient's terminally ill and you feel that CPR is going to be futile, the patient is just dying, in which case you're going to resuscitate and the patient will die after a couple of hours. So there's no point in that. But even if a patient has got a DNAR in situ, but you do not have access to that DNAR, you start CPR, that is okay. Advanced statements are living wills, okay? The general wishes of the patient, okay? If there are any religious wishes, there are documented surrogates, like we have next of kin. So the next of kin, you need to talk to them and you basically have to tell them that they are the people who actually have they participated in the advanced statements. Is it a legal and binding document? Okay. And as I said, advanced directives can actually have specific refusals for medical procedures. So Validity, it can either be oral or written. It has to be by a competent person, and the person's competency has to be acknowledged. Like if you have someone who probably had dementia for last 10 years and suddenly comes with the advance directive which was signed last year, I mean, you should start having doubts, like that can't be right. They need to be aware of the implications, in the sense that if you do not have this treatment, you're going to die. It should be very, very clear, and it should be a very clear statement. Okay, it is legally binding. Okay, if the caveats are, please do not do any unlawful or inappropriate procedures. Okay, place others as risk. So that is a very important thing. If a patient wishes something to be done to him which actually causes a risk to others, that is something where you can actually contest. And an advance directive can be changed at any time by the patient or the person holding his power of attorney. So what happens when you have an unconscious patient? What's the responsibility of the doctor? In this case, most of the patients will come to you unconscious. They've just had ROSC. Not everyone gains consciousness immediately. So you have to make your decision based on the best interest of the patient. You have to weigh the medical risks and benefits of any procedure, and you have to take into account what were the patient's last known wishes. Okay, relatives and others, they should always be consulted. All right, but they do not make the decisions. In UK, the ultimate decisions about resuscitation is made by the physician. If the relatives have a problem, they can always take a second opinion or a third opinion. In my ITU, we have multidisciplinary teams, or we at least involve a couple of consultants, 2, if not 3, to make a decision about withdrawal of care. In Scotland, they can have proxies. Always remember, if a patient's family comes and says, oh, I think you should do everything, but when the patient said, no, I don't want to be resuscitated, the interest of the family can never override the interest of the patient. And of course, there are patient advocates who, if a patient doesn't have capacity or patient does not have any relatives, there are certain organizations who can be contacted who act as patients advocates, and they can be consulted. Again, these advocates don't directly interfere in your management plans. They either say they understand and they agree. If it was a patient's relative, I would have done that. So they are very useful to have, and it's very important to document this. So the thing about benefit with futility is always a very gray area. So you should establish that there's no further benefiting continuing the care. You should establish that pain and suffering due to invasive care, which is given to the patient, is causing more harm than the benefit. So suppose you're going to put someone on invasive lines and put them on a ventilator, knowing right from the beginning that the outcome is going to be poor, then that's a very bad thing to do, because all these things in intensive care is very painful. Even lying there, right? And having to be moved every 4 hours. If you just try lying in the same position, you get a lot of pain just by that. Endotracheal tubes are very painful. Okay, invasive lines are very painful. So the pain and suffering you cause should not be greater than the benefit which actually you're giving by instituting treatment. Quality of life issues, it's very interesting, but quality of life issues is the patient's own perception of what is quality of life is. Just because we think, oh, this guy must not be having a good quality of life, doesn't mean that he doesn't have a good quality of life. It is one of the inner biases which we can develop as physicians. The quality of life issues for anyone having any kind of problem is his or her own. We can't decide that. Okay, rehabilitation time, it's very important to actually tell people. People think that if they come to ITU and they get better, they can rehabilitate very quickly. It is not true, because some patients who have prolonged ITU stay can take years to rehabilitate and come to their premorbid condition. And indeed, a lot of them will never come to their premorbid condition with which they were admitted to the hospital. And of course, in this gray area, always ask for the patient's wishes. This is the various things we limit care in ITU: ward-based care, treatment limitations, or we withdraw care or put someone on end-of-life care. This was something which I always talk about. People get confused between what is euthanasia, what is physician-assisted suicide, and what is palliative care. In UK, we do not do euthanasia. It is illegal. In UK, we do not do physician-assisted suicide. That is illegal. You can do it in some parts of America. Euthanasia, Switzerland is one of the countries which offers an euthanasia service. All we can do is palliate someone, which means we put them on end-of-life care. We just give him some medication to keep that patient comfortable. Palliative care is actually improving the quality of life before death occurs, and that is very, very important. Now, the conundrum again in India, it's your IPC 302, 304. You think about, you can't stop treatment or you can't withdraw treatment because that's considered as illegal. I have seen so many times on social media, political people coming in, and some politician suddenly makes a death into a big political hub. So you've got that problem to deal with. You've got the problem which occurs from social reasons, because of the relatives, because of pecuniary reasons. Some people want, nothing to be done for a person because you might be having a big inheritance, or sometimes they want everything to be done because they have this guilt in them. And of course, there are religious reasons too, for which we find that in certain communities it's very, very difficult to convince them to withdraw care. Okay, but it's a responsibility of every intensivist to provide relief from suffering due to invasion. Okay, invasism. You have to respect and create patient-centered goals, and every IT should have a pathway to provide end-of-life care. Again, this is the same thing which we talked about. The communication at this stage is probably the most important thing. You've got to be very empathetic because you're talking to someone whose loved one is dying. You have to be very honest because you have to tell them that that person is dying. Allow time for the message to sink in. You have suddenly someone's come, he's walked out of his house in the morning for work, comes back to you at around 12 or 1 with a cardiac arrest. The family sitting there, they just don't know what's happened. They just can't process it. Sometimes it takes time for this message to sink in and process. So sometimes repetition of that message is important, but don't be too repetitive, but allow time to sink in. And you can assess the response when you're actually talking to the relatives. You can assess how they are responding to what you're talking. And that gives you quite a lot of verbal and non-verbal cues to decide how do you proceed further with your talk. Now, there is always a guilt with the relatives, right? They always feel that they haven't done enough, or sometimes they have not been with their loved one, or some people live away from, for example, their parents or something. So that guilt that I could not do everything for that person is always there. And I find it very reassuring to the patients to the relatives, when I actually tell them that, there is nothing more they could have done. They did everything right. It just helps them deal with that guilt. Provide them reassurance, okay? And also, when you're in this situation where you actually have to withdraw, you've got to stress the importance of a good death. And you've got to say, see, this person has been suffering for so long, and it looks like his condition is going downhill. And, we can't make sure that he lives longer, but what we can do is we can make sure that we can give him a good death. We can keep him comfortable. We can give any medications to actually make sure the last part of his life goes well. Documentation, I cannot tell you how important it is. Okay, anything you talk, you document. Be clear, be very concise. Okay, if you did not document, it did not happen. You're not going to stand in a court of law and say, oh, by the way, I remember that happened. No. The only thing which will actually be involved is documentation. If you do not get time to document, sometimes we document in retrospect. So we go and we say documentation written in retrospect. That is acceptable. It's acceptable after the event was involved. Because in a CPR, if you're actually there busy doing everything, you can't do it. You can't record it as it happens. But ideally in CPR, a lot of places now has developed a chart. So you can actually write the timing and you can write what drugs you have given. It is quite useful. Just make sure you document who else was involved. Okay. Emphasize the capacity and consent of the relatives in case a person is arrested. You say you actually have got reasons for the recommendation. And it is very important to document the agreements, but equally important to document the unhappiness which occurs with this case. Can we prevent resuscitation? Yes. So we've got this form in the UK, which now even we have not gone to people filling it very well, but it is what is called as a respect form. And if you actually look at this form, it gives understanding of what the diagnosis is, what the patient wants, clinical recommendation, prioritize extending life, balance extending life with various comforts, or prioritize comfort, basically, which means that you don't treat but prioritize comfort. But things like the patient can tell you here what I value the most and what I fear the most, what he wishes to avoid, what he wants to get done. So this is a form which we are actually getting people who are chronically ill to fill in the community, so that we can have an idea, so they don't even need to come. So if someone, like when I started my talk, I said, more than 60% of the people die in a hospital. If they say that I do not wish to come to the hospital, I wish to die at home, then that is there. Okay, and then it's got a little bit about CPR too. This is our DNA CPR form. In my hospital, we use this DNA CPR form. This is, I think most of the places have a similar kind of form, giving you the patient's details, and then does the patient have the capacity to communicate about CPR? Yes or no, and if no, then go, who's making the decisions and things like that. Just follow the boxes. So summary of the main clinical problems and why CPR would be inappropriate. A summary of communication with the patient, if we had with the patient, or a lasting power of attorney for health and welfare. If someone has been given a power of attorney, then what we have talked with the relatives, we document there. Name of the multidisciplinary team who has contributed to this decision. And in the end, it's just the consultant signature which goes there. This is a very simple form for our end of life care. So it's just like DNA are completed, discontinue IV, discontinue cardiovascular support, discontinue renal support. The reason I'm telling you this is that you can, the first time, if you actually have a cardiac arrest and you find that someone's having a myoclonus, severe myoclonus, CT shows, there is a hypoxic brain injury, there is no point doing a CPR for that patient again. You should have a DNA CPR in that place. And suppose, like Suchitra showed you, neurological recovery, right? And a multimodal approach to that. And if you actually see 2 out of the 4 criteria, like if the neuron specific NOLase is high, as well as I get, this patient's not woken up for 72 hours despite not having any sedative drugs or having myoclonus, then we know that the patient's going to have or be in a persistent vegetative state. And that's the time when we actually discuss with the relatives and say, do we continue treatment because we are artificially keeping him alive, or do we discontinue treatment? And this is the kind of form we would put for them, which is called as an end of life form. So I end by quoting 2 very famous people. One is Socrates, who said that death may be the greatest of all human blessings. And Dame Cicely Saunders, who actually said, how people die remains in the memory of those who live on. So that is very important, because the relatives always remember how the last few hours of their loved ones were. And I think if you really need a palliative care recommendation, it's open access. You can have these 3 articles. This is the one which the FICM, or the Faculty of Intensive Care Medicine in UK recommends. That's me done. I'm going to stop sharing. And if there's any questions, we can take questions at this point. Okay, so I think there's one question. So where do we stand medically if we resuscitate a patient who has advanced directive unknowingly in the emergency department? Well, that's very easy, because that's what if you actually you have an obligation to start CPR unless you have seen an advanced directive, right? If you as a physician think that CPR is a patient's interest, you start CPR. If someone comes later on with advanced directive, this is what you explain to her and say that I do understand, you apologize, and you say, but if we do not have advanced directive at the time patient arrested, we as have an obligation to provide life-saving treatment. Anything thing hanging there? I think maybe the next question which Irene asked might be more pertinent for Sudipta. Sudipta, can you hear me, mate? Just show me a finger. Just show me a thumbs up. Yeah. Okay. So Irene's asking, in Indian scenarios, some patient party wants to stop treatment due to financial constraints. What can we do? I'm sure in your ITU, you might be seeing cases like that.
This is a not very uncommon scenario when the family members do not want to continue aggressive therapy because of the financial reason. Now, a few lines about the Indians medical legal scenario. It is developing, but it is still very gray. That we don't have any clarity that if the family member who has brought the patient for treatment now does not want any treatment, can you de-escalate when the medical person feels that treatment should be continued? There is no clarity in that regard. I can share what we are practicing in our hospital. That mostly what we do, we are in a cancer hospital. So we look at the basic background of the patient. What is the clinical status, whether the cancer under control or not, whether there's a progressive disease. So if the patient has a progressive disease and there's no future treatment plan, so we agree with the family member. We keep the financial, because of financial reason aside, we document it like that the patient has a progressive disease and the overall outcome is guarded. In this background, family does not want to continue aggressive therapy, which was not working also. It is obvious that things are not working, otherwise family would not have de-escalated. We document like that, and we document that both family understand that with no further aggressive therapy, things will can go down very fast, and patient can have a demise very fast compared to what was expected. And we take a signature from the stakeholder, and we continue like that. We give the best supportive care and continue either in ICU or sometimes even we extubate and shift the patient to ward also for best supportive care. Problem happens when the patient is improving or the disease is under control and now the family does not want to continue. Then it's a very difficult decision. And if we take it on an individual basis, there are times we suggest them that, okay, you do not able to continue here. Can you consider to shift to a government hospital? We communicate with 1 or 2 government hospitals and try to shift the patient there and ask them to make the necessary arrangement. Sometimes we know people there are some colleagues which are in different government hospitals. We try to communicate with them and try to shift. There are times family doesn't even want to do that. They just want to close it here. They don't want to extend the agony of the patient sometimes. We document it in a different way. We do not document that this is because of the financial reason. And a lot of time it takes times for us from the ICU doctors, from the family member, from the administration. So sit down and discuss. Luckily, I work in a trust hospital. So sometimes we get certain funding from the hospital in this type of scenario just to bypass that gap. That suppose family decide not to pay from today and be able to sort it out by another 24 to 48 hours. Hospital has okay to support us for that next 24 to 48 hours. But honestly, we do not have any fixed protocol. We try to understand the vibe of the family member. What is the reason not to escalate? And we try to put the documentation accordingly. But it is not an uncommon scenario.
Yeah, okay. I mean, that sounds like a nightmare scenario, isn't it? Because it's an ethical and moral dilemma for you when you think that you can actually save a patient and
Yes.
just because of the money you can't save. So, yeah, no, thank you for that answer. I'd actually ask you another question because it's again something to do with India. It says, are there any protocolized DNAR guidelines in India which we can follow in our ICU or rely upon legally in the court of law?
No, I'm not aware of. There are critical care. I can share you from the critical care perspective. There are doctors like Dr. R.K. Mani and his team who is very much instrumental to develop a palliative care or supportive care services related to critical care. A lot of times the organ supports are futile. We know that even though we are continuing the ventilator, with the dialysis and all those things, this patient is not going to survive in a long run and not going to have a reasonable quality of life. So in that regard, there are a lot of recommendations, there are a lot of suggestions, position paper, those things have been there in Indian practice. But if you ask, there's a law which we can blindly follow, thinking that we'll be medically safe. I'm not aware of any law. One aspect that has been started working, the government has started working, is advance directive. It has been put into the parliament, and still it is not a law. It is going through the standard process to become a law. But there is an option that you can go to a lawyer and can say, okay, these are the supports I do not want in future, depending on your clinical condition. I don't want ventilator, I don't want dialysis. You can do that, and that part is presently developing. But in terms of DNR, there is no structured format that one person can blindly follow.
Okay, so but if a patient says that I don't want to be resuscitated, then do you resuscitate him?
No. If the patient says that I don't want to be resuscitated, we document it accordingly. We involve the family member and we try to follow that. But problem is when the patient needs resuscitation, then he is not in the picture. He is probably unconscious or really sick to take a call. Now, if the family member is absolutely of a different opinion, maybe so we have to do it because my father is sick or mother is sick. I understand he don't want it, but he's thinking in a different perspective. We are thinking from a different perspective. There are times we are forced to do certain amount of resuscitation just to satisfy the family member's emotion. There are times that we could not tell them that no, we are not going to do anything just because family has requested it. There are times we have to do certain amount, like maybe shifting to ICU, maybe giving him an NIV, and maybe very rare occasion may need to intubate and then sedate him. Obviously, we do not prolong the life because that is the wish of the patient. That is the primary responsibility for us to respect it. But there are times just to satisfy the emotional need of the family members, we have to do certain things which we would have preferred not to.
Yeah, I think I understand that it's again one of those very difficult, unless you have people supporting you like the government. It's a very difficult thing to do, because I think there has to be some kind of law. We are very lucky here because the patient's wishes are paramount. Even if the relative comes and tells me resuscitate, I won't, because the patient has said do not resuscitate.
Right.
Dheeraj is not seen.
Or I thought I probably need my.
No, Dheeraj is. I don't know what happened. He is not seen in the.
I think maybe network
Did he
issue.
leave? Maybe accidentally, because
He's
I
still
think
there.
it's better
Otherwise
to.
the meeting would
Yeah,
have
yeah,
been
he's not seen.
but he's still there.
I better stop live sharing. Yeah. Now he's seen. Acha, his Medusa is in that particular with that particular name. He's there.
Yeah. So the other question was that in cardiomyopathy, how is echo useful and what is the normal ejection fraction? That was a question.
I don't think it's the right question for me because we rarely deal with the cardiomyopathy, to be honest. And our main physiological target remains same, irrespective of the underlying pathophysiology. We receive certain amount of patients with underlying cardiomyopathy, specifically in the background of multiple myeloma. They come with amyloidosis and a cardiomyopathy, and they have a baseline fluid ejection fraction, maybe around 35. Mostly they have a diastolic dysfunction rather than a systolic dysfunction. We don't do anything extra, to be honest with them. We continue with our conservative management, try to maintain a balance between oxygen demand and supply. And also from the cardiological point of view, also whenever we take opinion from a cardiologist, there is nothing much to add from their side also, except that the control of the disease, better control of the disease gives a better outcome. And problem is that they have a associated renal dysfunction. So chances of ischemic heart disease, chances of thromboembolic disorders are significantly high. So we have a very low threshold to hold back anticoagulant in this subgroup of patients. Even with a platelet count of 35,000, 40,000, over 50,000, we are very comfortable to give make a pharmacological thromboprophylaxis. Even from 35, 40,000, we try to provide them because there's a very high propensity to develop ischemic heart disease and thromboembolic disorders.
Yeah, no, that's a good point. And I think it again depends on what kind of cardiomyopathy it is. I mean, if it's a hypertrophic cardiomyopathy, which is obstructive in nature, or whether it's a ischemic cardiomyopathy, where you actually have got significant. So if you have an ischemic cardiomyopathy and you've got a lot of area of your heart involved, then you probably have a global ejection fraction of which could be anywhere from 10 to 15, 20%. If you've got alcoholic cardiomyopathy, that's sometimes we see it out here because of quite a large consumption of alcohol, but they can have ejection fractions which are low as 20, 25%. I think in answer to Dilna's question, it's just basically the ejection fraction is categorized based as either you have got severe, moderate, or mild impairment to your systolic function. But you also raise a very good point about diastolic dysfunction. It's one of the things which is quite underestimated because severe diastolic dysfunction can cause what we call as preserved systolic ejection fraction heart failure. But that's a discussion that's a completely different discussion. So Suchitra, thanks for coming. And I think if any of the other faculties want to put their video on, we could have a few more questions. Sudipta is answering all of my questions. So anyone can pick this up for me.
Sure.
So what do you think about changing hands during CPR? We were talking about teamwork, right? And Megha actually mentioned it's not very easy to give CPR. I mean, those of us who've given it know that after 2 to 3 minutes, then your rate decreases or your shoulders start to drop. So anyone wanting to answer that question, how do you?
So can I answer?
Yes, please do.
Yeah, if we have to change in hands in CPR, what we do is after 5 cycles of CPR, like 5 cycles, at the time of pulse assessment, the person assessing the pulse will go to the head, like the person who gave chest compression assesses the pulse. So that person can go on the head end, and the person on the head end can come on the chest compression after approximately 2 minutes. Then they can perform the for 2 minutes CPR, and again they can interchange. And they can interchange in such a way that they do not cross each other so that there is no confusion. So from chest to head end and from head end to chest compression, they can rotate amongst themselves.
Oh, that's a very good idea. So what effectively we are saying that ideally no one should do CPR for more than 2 minutes, right? Megha?
No, it is not that, but if there are 2 rescuers, then AHA also says in the algorithm that you can interchange after 2 minutes. I mean, 2 minutes after 2 minutes, because there is some gap. So we can interchange while the person is giving the breath. One person is giving the breath that can again come on the chest compression, and the person on the chest compression can go on the airway. That is the time after 2 minutes or 4 minutes or 6 minutes, but that is the time when they can break in and change their roles.
Okay, Megha, yeah.
To add to this, when you are actually following the ACLS protocol and when you will be doing the codes at the stations, you will learn a good practice thing like stop, switch, analyze. After every cycle of 2 minutes, so we stop, switch, and analyze. In that time, we are changing the hands and we analyze the rhythm and then resume CPR. So if there is any shockable rhythm or all such things you are going to do. So this word of stop, switch, and analyze helps in changing the thing,
That's a very good thing. Like stop, switch, analyze. I think that should be the mantra everyone's listening to. And I think that's, 2 minutes is probably the time which we think people can effectively give CPR. After that, they start getting tired. And unless you've got Lucas or something of that sort, which I think a lot of institutes should have now. I mean, we have a Lucas. And sometimes as intensivists, we actually are very tired of that because they'll keep continuing CPR indefinitely when we say how long are you going to continue just because it's a machine, you're not worried about it. You're just allowing it to give compressions. See, the other thing about this, Anju, you want to say something, Anju?
No, sir.
No. The other thing I wanted to say is that, so just for the sake of the people who are attending here, is there a trick on when to give adrenaline depending on these cycles?
Okay. Dr. Anshu, if she'll be a better position to answer this, or
sir, can you repeat the question?
Talking about the
So
ACLS. Every
I'm
alternate
just saying,
cycle is when you give adrenaline. That is how we remember.
So
When-
why? So the reason they do that is basically when you have a cycle which goes for 2 minutes, right? You give adrenaline every 3 to 5 minutes. That's what's the recommended thing. So each cycle is a 2-minute cycle. So every 2-minute cycle, we always start analyzing the rhythm, switch, and do whatever you mentioned. So after 2 cycles, you actually, if it is a asystole or a PA, you continue to give adrenaline. So that way you always maintain that you're giving adrenaline between 3 to 5 minutes. So each cycle is 2 minutes. You finish 2 cycles, give adrenaline. So in that way, you will be able to give adrenaline every 3 to 5 minutes. And that's what is commonly practiced. So coming to the other very tricky question that someone asked was, when do you guys stop CPR? And I would like to take the opinion of everyone on what your normal practices are. Umar, do you want to have a go at this one?
So there is no clear-cut answer to this question. The only thing which I can say is that if the confounding factors like hypothermia and other poisonings and other aspects of known causes of cardiac arrest are ruled out, and if you have done a reasonable CPR with good chest compressions and all the protocols being followed, and with no return of spontaneous circulation for 40 minutes to an hour, then you can call it a day. That is what we generally do it. But this has its own caveats, in the sense we may not be giving CPR at the most ideal location, in the most ideal form of way, with the proper trained people. I mean, those kind of caveats and those kind of vagaries in the treatment can, of course, result in problems. But yes, if there is no evidence of return of spontaneous circulation within 40 minutes to an hour, with all the possible measures and the drugs and shock and whatever is recommended in the algorithms, and all other confounding variables are ruled out, and chest compressions are good enough to demonstrate a good CO2 graph, then yes.
Okay, that's
So can I add on to this?
Yes. I'm asking everyone about this, so it's fine.
Yeah. So it also depends on whether it's a witnessed arrest or a unwitnessed arrest. If it is a witnessed arrest, the person has collapsed in front of the person who is giving CPR, then definitely that it has a better chance of survival. So we may prolong the CPR as much as our capability. And second thing is, depends on the clinical condition. Suppose you are giving CPR to a patient who is admitted in ICU, who is you know the clinical condition, the medical associated condition, that patient is not going to survive because of the clinical condition, like patient is in severe renal failure or some other such condition, then, or sepsis, then you may not be prolonging the CPR for a very long time. So it depends whether the patient is how is the clinical condition, and is whether you have witnessed the arrest. All these things also matter when you decide how much duration the CPR we should give.
Okay, so
To
Megha,
add to
yes.
that, to add to Dr. Anju's point, if the patient is suspected hypothermia or in cases of drowning, then the CPR sometimes may need to be extended to up to 2 hours or get the temperature to normal in order to have ROSC and have a better outcome. So it can be extended sometimes if you know the situation.
Okay. Prasanna, any opinion?
I think everyone has summed it up very well. But I would like to again reiterate that it's a personal decision. There are no legal guidelines in India as of now that you need to continue CPR for a certain amount of time or something like that. But yes, you have to take all the conditions into consideration, whether ideal CPR is being given, whether the settings, the surroundings are safe, and whether the underlying conditions were already being treated. As Dr. Anshu said, if the patient is in an ICU, the underlying conditions are already being treated. So the chances of that patient returning to ROSC is much higher than a patient who has not been treated at all.
Yeah.
So you have to take into consideration all these things before you take a decision to discontinue CPR.
Suchitra madam, anything from your side?
I don't think I'm not a person who can answer this because I don't have any experience in that. But what I agree with what Prasanna says, that unless and until means it can be a relative decision also that we want to continue with the CPR if at all they know that it's going on, and then it doesn't have any time limit.
Okay.
But as a doctor, if we would like to continue only if there are chances of sort of very good recovery, good neurological recovery, and then only we will like to continue.
So I think now I'll ask an intensivist and I'll give you my opinion as an intensivist. So Sudipta.
I think I will agree with the majority of the points, but only concern is that if you continue for a prolonged period, most of the time, even if the patient survives, the neurological recovery is poor. That makes us in a very difficult situation. The patient is now alive. There is nothing much to de-escalate, maybe on minimum oxygen support. Now the man in a vegetative state. So if we have to continue CPR for more than 20 minutes, 15-20 minutes, we are very, what should I say, circumspect about it. We discuss with the family member. Maybe one team is continuing with the CPR. One of the senior person have go and have a talk that even if the patient is coming out of this crisis, his neurological recovery will be very, very dodgy, unlikely to have a good neurological recovery, and overall the quality of life will be very poor. So unless there is a definitive reason, like maybe very unexpected arrest, young person in the world, no one knows what exactly happened, unexpected arrest. Now the lot of family emotions are also involved. So now we have to survive, and then we'll see the another day in terms of the final outcome. Then probably we continue for a very prolonged CPR. Otherwise, we are not that keen to continue more than 20-25 minutes, at max 30 minutes, because most of the time the neurological outcome is poor. And as you were, Anju madam was mentioning, in ICU, what happened? Most of the factors that is correctable has already corrected. Now, if the patient has a arrest, and even if he resuscitate him, he is going to have the similar arrest another after 30 minutes after. So in ICU, we are in a sick patient with a ventilator or inotrope. I am much reluctant to give a CPR if you have an arrest, because I don't think I have any correctable factor to work on it. Whatever could be done has already done. Now, even if he resuscitate him, he's going to have an arrest after another 4-6 hours. So that's why we probably do just a basic CPR just to document and all, because as we don't have any medical legal issue, and just to satisfy the family member, yes, we have tried at the terminal point also, but nothing could have been achieved.
Yeah.
Actually, I know one incident which happened in a case of a cardiologist, which cardiac surgeon. He was himself a cardiac surgeon, and his wife had a cardiac arrest. I mean, she was getting down from the stairs, and she was a dentist, and she was getting down the stairs, and she collapsed. And at that time, he had given me, this is a real incident. He gave cardiac the resuscitation. He followed for nearly 45-50 minutes till the ambulance arrived. And till he said that he was actually, when the ambulance arrived here, the people are not very much of intubation and all. Now, the people who come through the ambulance, they may not, that the doctor was not very competent enough. So he intubated his wife himself, and the wife survived.
Yeah.
So it depends.
Proper neurological.
Yeah, she didn't have any comorbidities, comparatively young. And so that time he literally, this is which I heard from him only, and this is a real story.
No, and it is a very exceptional and an exception.
Yeah, true. Because
so the people are interested, that's the reason why it's very interesting. I heard from the anesthetist first and then from an intensivist, because all these patients end up with us, okay, and they do not do well. If you actually have got, so I would agree, my normal time would be around 20 minutes. After 20 minutes, if I don't have return of spontaneous circulation, I'll call it off. I'll just say, you're not going to have a good neurological outcome. And especially if the patients have comorbidities and stuff like that. If it is someone young, we might continue it for longer, maybe around 30 minutes. But after that, you definitely know that the neurological outcome, because it's a period of global ischemia. As I said, even with CPR, your patient is ischemic. It is a period of global ischemia for that amount of time, and the outcomes are not very good. The people who do well after CPR are the people who actually respond to CPR very, very quickly, especially the shockable rhythms and stuff like that. Megha made a very interesting point about drowning, hypothermia, because it protects the organ. And that's the reason in those conditions, you actually have to continue your CPR for a longer amount of time. Now, I will give you another example of a place, of a condition where your CPR has to go on for 60 to 90 minutes. And this is when you're actually suspecting a pulmonary embolism and you've given a TPA. So if you thrombolize someone and you suspect that there is a pulmonary embolism, you have to minimum, the European Society says, continue CPR for a minimum of 30 minutes, and it can be extended to 90 minutes. So that would be the only condition where you actually have to do that, because it takes time for the TPA to work. And sometimes a second dose is also recommended after 15 minutes. So that if it's P, you continue to do that. So, classical echo, which Sudipta showed, which showed dilatation of the right ventricle massively. And if the patient then has got a DVT, or you can see a femoral or something in the femoral or the iliacs, then you definitely have to thrombolize them and you have to continue that. Because in those cases, the outcomes are good. But usually you have to have a machine. You have to have something like a Lucas. It's very difficult to actually continue good quality CPR for that long. So I think this is the thing, isn't it? Because I think when we started this discussion and when the answer came from Uma and she actually said there is no clear-cut answer to that, that was the clear answer. There is no clear-cut answer to this, and there's never going to be an agreement. But generally, as a ballpark figure, 20 to 30 minutes is something you should at least minimum try, unless you know that you're doing it just for the sake, you think that the patient is not going to survive and the relative is sitting on your head, in which case we give a couple of shocks and a couple of CPR cycles just because we are treating the relatives. In that case, we are really not treating the patients. And I know it's an unfortunate thing, but sometimes you have to embark, and sometimes that has to be done, and it's done in some units. For us, it's in the UK, it's not much of a problem doing that, but or not, because we don't do anything like that. But I can understand there are other factors which can be involved. Okay, so yeah, tell me.
One point, sorry. And at least sometimes my junior teams become very overzealous and they like to continue CPR for a very longer duration. We have some bad experience, like some patients who have continued CPR for 35, 40, 50 minutes, 60 minutes because of the pressure of the family, and now the patient's ROAC has achieved. Now patients gradually improve with the initial supportive care, because even in this type of patient, we go do hypothermia, keep the temperature around 34, 35. We keep them sedated, paralyzed for 24 hours, then gradually raise the temperature. So probably the supportive care goes on for another 72 hours, 48 to 72 hours. Now there are times when the patient responds to this supportive care. Now after 72 hours, patient is hemodynamically stable. Some of the kidney function is okay, reasonable, maybe a little bit of heat, but holding on. Blood pressure is okay, oxygen recovery is not that great, but the brain function is gone. Now we are stuck. Now we don't know what to do with this patient, because families say, I don't know what to do, because he is alive, we need to continue. And even in this situation, if they stop paying, you are really, really stuck, that you don't know what to do when you know this patient is not going to have an outcome. So usually I tell my team, unless you feel that patient is going to have a reasonable neurological recovery, don't try to prolong it very fast, because you may get a vegetative patient with multiple organ support stuck in my ICU.
Yeah. So I think it's a very important point. And that's the reason why people have to have awareness and education. I mean, I think now I know in India, they're doing this calls course, and, people on the floor know how to do CPR. Hopefully the benefit is there. And sometimes we get it with the ambulance crews who come in with like adrenaline infusion going and saying, oh, this patient's ROSC. I said, okay, stop the adrenaline and see what happens. And the ROSC goes and say, you just because you're adrenaline, the patient's doing that. So, but I think one of the things is that, we have to encourage the people being slightly overzealous, because some people will be saved because of that. It's a difficult decision. I think ultimately, that's where you struggle, isn't it? For us, once we have come to ITU and we've decided that it's not going to benefit, then we are not going to continue treatment. But in India, that's a very difficult thing, and that's probably where you guys get stuck. Now, there's a question on by Sonai Datta, who's actually said, how reliable is the measurement of IVC diameter by ultrasound in ICU to assess fluid responsiveness in patients on mechanically ventilated patients on inotropes?
So basically, if I answer in one word, it's not reliable. So it is diameter of the IVC is as good as the central venous pressure, which need to be measured invasively, and IVC in a non-invasive manner. Because except that, diameter does not have much clinical significance. we need to understand the diameter. Large diameter indicate either there is a volume overload or there may be a pressure overload. It can be any of them. So volume assessment in a patient who is on positive pressure ventilator and shock just from the IVC diameter is not at all possible. If it is extreme, like it is absolutely collapsed, maybe 0.5 centimeter, probably this patient is going to be fluid responsive. If it is more than 2.5 centimeter, probably unlikely to be fluid responsive. But in between, which most of our patients will be, is very difficult to make any comment.
Yeah, I think it has to be looked at in its entirety, not just with what the IVC is. And you got to look at the RV too, because if you actually got severe tricuspid regurgitation, your RV might be empty, but your tricuspid, your IVC will be quite stonking. So there are conditions which throw a certain boat. So I think just looking at IVC diameter by itself, it acts as a guide. I mean, I think you can look at it as a trend to just show, whether the patient's fluid responsive or not. So the patient might be, and it's very important to realize one thing, which I keep telling, just because someone is fluid responsive does not mean that the patient requires fluid. It's a very important thing that, every heart responds to fluids because of the Starling's law, but it is not necessary that every person then requires fluid. So it's important. Fluid is a drug. There's a question which says that I have seen in some CKD patients on MHT, which I think is hemodialysis, is it? Their chances of revival is much better after prolonged CPR. Why is it so? Is that, I have never seen that. I don't know anything about that. Does anyone have any comments? Okay, Prasanna. Oh, you're the urology specialist, so you see a lot of these patients.
Yeah, so I see a lot of patients with CKD and undergoing hemodialysis. Well, if she has observed that they are revived with prolonged CPR, that's something new for me. Because what I observe is most of them are so decompensated towards the end that actually CPR doesn't even work on them. So, but yeah, the reason she might have seen that is probably because they are on drug therapy and the other aspects, the 5H, 5T is being taken care of. So probably for the time being, they will be revived, but probably they might have another episode within the next 72 hours, which is not a good thing.
Okay. All right.
Most of these CKD patients, they generally have hyperkalemias. So if that is recognized and corrected, they have very frequent episodes of hyperkalemias. Yeah. So if that could be because of correction of hyperkalemia, which we can do it with the medical means. So correction of hyperkalemia will lead to probably return of spontaneous circulation. That is one of the.
I think it's a very, very interesting point. And what you give you give calcium to along with that, which is a good inotrope and helps. But the thing is that the only caveat to that is you've got to realize that people who are on hemodialysis, they're not CKD, they're end stage renal failures, and these are the guys who actually are used to massive rises in potassium. I've seen patients I saw one with a potassium of 8.5 or something, and he was still going on. So that is the other thing which you got to say, that they are quite resistant to changes with hypokalemia. But you make a very interesting point. Maybe it's an easily correctable cause, and this is why the 5Ts, 5Hs, they are very, very important. And the role of echo has just come so much, because previously, if you're trying to not give fluid to a patient whose ventricle is absolutely empty, like Sudipta showed you a hyperdynamic LV, it's like flogging a dead horse. I mean, there's no point doing that. You just have to correct whatever are the correctable causes. And I think people should always keep that in back of their mind while they're doing this resuscitation. What are the 5Hs, 5Ts? Try to rule it out. You might not be able to treat everything, but you'll just be able to get a rough idea of where we go with that. So I cannot see any more questions, but I don't think so. There are a lot of people around anyway. So is there any comments which you guys want to make, or anything at the end? Anyone? Okay. I don't think so. I think everyone's tired. It's gone for an hour longer than we thought it would. I would actually, I really, really want to thank all you guys, because you just picked up this in a matter of an hour and volunteered. So the CME was possible. Hopefully I'll see you around. We are planning quite a lot of ICU CMEs going forward. Yeah.
Just want to say that kudos to Irene for taking initiative for such a CME, and she's doing a very good work.
Yeah,
And
she's actually not turning her video on. I don't know.
I don't. Maybe she is.
She's busy. She's doing a
but
case.
anyway, yeah. Kudos to her.
Yeah. No, I think it was very interesting because what she mentioned was that they do not have people who can do who are ALS certified, or I don't know what the word you use there is, and because they don't have faculty. For them to get faculty, they had to have a course, and that's why she was organizing this course. And when she was organizing this course, all the faculty who are coming there are, she has to take care of their registration, study, like for gas events, we usually pay our own registration. We do everything on our own. We arrange everything on our own. So that's why I think she was having. So when she came and told that she would like to have, this kind of a CME and wants gas to help us, I think she's been a very core member of gas. We thought, we should step in forward and we should do that for you. So I am really, really thankful. And with that, there's a last question. I was going to end now. It says, like, how do we perform CPR in patients with a penetrating chest trauma following RTA? Post-arrest.
Sir, that will follow ATLS protocol.
Yeah.
So, of course, if the patient is combined ACLS and ATLS protocol, that is something different. Penetrating chest trauma, follow ATLS protocol, ABCD with cervical spine control, and chest compressions. He must be meaning with the penetrating chest injury, how you will do chest compressions. Remember not to remove the penetrating device and follow the standard protocols.
Yeah. And if the device is removed and there is a big enough hole, just put your hand and do internal cardiac.
Yes.
I mean, I've done it on a couple of patients. So you
can do physical cardiac
because you do tend to have a little bit of hemopericardium too. Sometimes you just have to release that too.
Yeah,
but
and otherwise
again,
try open cardiac massage. Open cardiac massage.
Yeah, that's what. Yes. That's what you were saying. All right. Okay, with that, thank you very much. It's been a long day. Thank you very, very much.
Thank you, sir. Thank you, everyone.
Thank you, sir.
And as we said,
Thank you, thank you, Game. Thank you for this wonderful.
Thanks for the opportunity.
This is a very good day for us.
Excellent.
Thanks for including me and giving the opportunity. Thank you.
Thank you so much, all of you, faculty.
Thank you. Bye-bye.
Thanks, Irene. Bye-bye. Bye-bye. Bye, everyone.
DP, which my this one profile is doing, it's my daughter's doing. It's coming all of the black thing and all those army things. Okay.
Yeah. I was wondering, I didn't want to ask you because
Sorry about that.